I'm not going to sing. So you can probably all see that there, and we've got a bit of a kind of technical, logical thing to get used to, but we will get used to it. And I'm going to be talking about the illness in general, and the others will tell you what they're going to talk about when they come on. Let's just see if it works. Yeah. And so we're going to say, first of all, what is ME/CFS? And I think we now know that it's usually triggered by a viral illness, but not always. There tends to be a family trend, a genetic vulnerability. And we know that there is a lot of overactivity in the immune system and in the brain. The brain shows signs of inflammatory changes when they put people through scans. And all the biochemistry of the body seems to be really screwed up. And I think Warren's the person who will address that shortly, tell you a little bit more about that. The microbiome becomes imbalanced, and that's all the bugs and things, the bacteria in your bowel can become imbalanced. And of course all this leads to a lot of symptoms, which I'm sure many of you in this room are very familiar with, so I won't spend a lot of time on that. So-called epidemiology is a kind of the statistics of it, really. And we think there's probably around 20 to 40,000, I know that figure's a little vague, in New Zealand. That's comparing it to the incidence that's been measured rather more accurately overseas. You can have very, very mild illness, so these people will still be able to go to work or school. It affects every age group. Some people who are not here today will be very severely afflicted and stuck in bed, maybe in a darkened room. And there tends to be a higher incidence in females than males, so there may well be hormonal links. Predisposing factors, these mean the things that might lead you into getting something like this, and we've already mentioned the genetic predisposition. There may have been some sort of mental or physical distress or overuse in the lead up, so there may be a tendency, some sports people get this, they're over exercising, there may have been exposures to toxins or an accident. Certainly lack of sleep is a big issue. Many people who are shift workers like airline pilots or nurses or new mums, lacking sleep, again, they perhaps don't get over things so readily, so their initial viral illness tends to then trend on to something that we might then end up calling chronic fatigue syndrome. But most of the time, a virus will have been the trigger point, something like a bad flu, or maybe glandular fever or mumps or something, and certainly the COVID thing is becoming talked about a lot, and Sarah will be telling you more about that shortly. Who gets it? Well, certainly sports people are prone to this illness. They're not the only people that get it, but I just put that up to show you that even the most healthy person can succumb to this illness, pushing themselves perhaps very, very hard, get a bug, and so on. So we have a little case study here, just as an example. A young man, busy life, gets a bug, goes to bed because it was a nasty bug, but he goes to back to work feeling very, very tired. Someone's showing that they can't quite hear, is that right? Good, sorry about that. And he spends time in bed, gets better to a level that he can go back to his sport, but after the practice run he gets what we call PEM, which is post-exertional malaise. He's really, really exhausted, not able to really carry on with his work the next day. It's a very delayed effect, and then he's unable to go to work. He has to stay in bed. The symptoms continue, they're up and down maybe, but they just don't seem to go away. He ends up, of course, going endlessly back and forth to the doctor, gets widely investigated, but 6 months later he's still unwell, still unable to work, and according to the diagnostic criteria that we use, we can make a diagnosis of ME/CFS. And that's, again, a typical picture of what may happen in this illness, and it's a little bit technical for some of you, but the idea is that in the early stage you get a nasty bug, your immune system fires up into action, working away at killing the bug, and in about 90% of people, a week or 2 or 3 later, the person has recovered, the immune system's come down. But there will be a number who go on with illness for a number of months. Some will be slowly recovering, and at 6 months the majority will have recovered. We will have labelled them as suffering from post-viral syndrome. But there will be another percentage, and this is an example in glandular fever, for example, where maybe up to 1% of those people will still be ongoing ill over quite a long period of time, and they're the ones we're going to say suffering from chronic fatigue syndrome. The symptoms, well, I won't go into a lot of detail, but you can just wave your eyes down that list, but certainly the symptoms are many and varied beyond that list. The list is just the perhaps most prominent symptoms we see, and particularly this so-called post-exertional malaise, where exercise causes you to become really much, much worse or exaggerates your symptoms. And the cognitive or brain symptoms are particularly prominent, and many people say they suffer from what they would call brain fog, or mental fatigue, or running out of steam very, very quickly if they try and do their computing work or reading a book or trying to work. And sleep disturbance is very, very common. I think the majority of people with this illness will say, well, even if I sleep for 14 hours, I'm just not refreshed. And many, of course, are wakeful all night too. I'm not going to go through all that list in detail, but just to show you that for the last 70 odd years there has been a huge body of research going on, going through all the different systems of the body, and of course with much more sophisticated, people are making things. You can't hear me?
No, not very well.
Okay, is that better? Is that better? Okay, well obviously the microphone's very sensitive, so I'll try and almost swallow it. But anyway, there's all that research going on, and certainly, you know, we could spend the whole session now on any one of those headings, really. And the latest research, again, covers all these different bodily symptoms, different types of body work that's going on, sleep studies, exercise studies, studies of your genes, and looking at how best to treat the illness and so on. And also there's a lot of research looking for what we call a biomarker, and a biomarker is something that gives us an answer. You know, if you're a diabetic, for example, you have high blood sugar if you're not on treatment. Very specific sort of set of tests there. We haven't got that for this illness, so everyone's yearning and hoping that one day there will be a blood test or some sort of test that can give us a total answer. And so people are looking at all these different things to try and find something that's very, very specific to the illness. And it has to be specific to the illness because, you know, you've got a lot of illnesses with similar symptoms, multiple sclerosis and all sorts of rheumatological illnesses and so on. And you've got to have a test that says, yes, this is this one illness, this is definite. And that's going to still be a long, long way off, I think. And there are a lot of drug trials going on too, and I've got 2 there in red which I might have time to talk a little bit about or answer some questions on, but all these other drug trials again are a little bit, they may help, let's try it, let's see if there's something that can work there. And that's I've stolen from Warren, who will be talking to you later. He might even show you the same one. But it's a kind of jigsaw that's coming together. And, you know, maybe each time I talk, I should be hoping that we fill another gap. So how do we make a diagnosis? Well, again, there's no set blood test. And so we have to do the usual things that doctors will do when they're looking for what is going on with this patient. And we take a very careful history, we examine the patient, take routine blood tests, and you do all the investigations that might be essential and appropriate for that particular person. And it's really important that we assess the person psychologically as well. A lot of people say, oh, I don't want that, you know, I don't want to see a psychiatrist. They might say I'm crazy or it's all due to something in my head. But I say it's important that we prove it's not just something that, you know, you brought about yourself because of stress. We want to prove that you've actually got a physical, real illness. And so we have sets of diagnostic criteria, which is sort of checklists that we can make sure the person fits that checklist, and then we're more likely to be able to make the diagnosis reliably. A number of overlapping conditions, and I'm sure there are some of you in the room here who have some of these conditions, and again, I haven't time today to go through all of them in detail. We could do a whole talk on any one of these things, but the commonest ones that do overlap are the top two, which are what we call POTS, which is that tendency to feel very woozy and lightheaded if you stand up suddenly, or if you're standing in the heat for any length of time, and you may even faint. And fibromyalgia, which is not a disease, but it's a set of symptoms which often go hand in hand with people with ME/CFS, a tendency to interpret pain abnormally, so that pain is very much more severe than it ought to be. So how do we manage it? What do we do to try and make sure the person has the best possible chance of improving their life, and hopefully for some people getting over this illness, and there will be some people who do recover completely, so we always have to be full of hope. So a correct diagnosis in any illness is important, and focusing on stress management is important, because any stress will aggravate every illness in the book. So if we can keep our stress levels under good control, we're more likely for this person to get better. Exercise needs to be curbed usually. People get over enthusiastic because they happen to feel a bit better, and they're kind of doing quite nicely, coming up slowly, go play rugby, crash right down. So, you know, bearing that in mind, cautious exercise. There's no special diet that's going to fix this illness at all, and many people will have tried every diet in the book, but I think, you know, if you stick to good balanced nutrition, you can't go too far wrong. But people with this illness, generally, we recommend that they have plenty of extra salt, because there is some good evidence that that can improve some of the symptoms, and we sometimes use the drug fludrocortisone. We sometimes use supplements, but apart from the 4 I've got written down there, I generally wouldn't recommend people to spend their life savings on all the stuff being advertised out there, because, you know, there's not a lot of evidence that if your diet is good, you need a lot more other supplements. We look at hormones, particularly in women, because women are more prone to this illness probably than men. So I will recommend often younger women going on the pill, older women going on a hormone replacement, because this can alleviate some of the symptoms. And we treat the POTS, that lightheaded wooziness. And sleep management is really, really important. And the drug of choice generally will be one of the so-called tricyclics, something like amitriptyline or nortriptyline, a very, very tiny dose, taken several hours before bedtime, because everything in this illness goes slow. So if you take it right on bedtime, it may take a while to kick in. We can have questions about some of these things later on if we have time, but pain management is really important, because pain creates huge stress and also makes people very, very hard to sleep, hard to do anything really. So we have to treat pain efficiently, and there's lots of things being trialled there. with any drug with this illness, we have to start with very low doses because people are generally quite sensitive to medication. I won't go there. We do a lot of sleep studies, and we find that most people with this illness do not get restorative sleep. They may sleep and sleep, but they just don't feel refreshed. And so getting a good sleep routine established is very important. And, you know, again, I can't emphasize enough the importance of turning off all your electronic gear for a good hour before bedtime, having a good routine, and then probably taking some sort of medication to help lead towards recovery. Because during deep level 4 sleep, you produce all the hormones and chemicals that have a really powerful healing effect on your body. A lot of drug trials I've already mentioned. There are other ongoing issues that, oh dear, sorry. Pregnancy is not a bad thing for people with this illness. There are many young women who are very anxious about the risk of pregnancy, but the majority of people do very, very well in pregnancy. They tend to have production of high levels of the estrogen hormone, and this seems to have a beneficial effect at improving pain, improving sleep, and also quietening down some of the abnormalities in the immune system. So not everyone will do well in pregnancy, and we never know who's not going to do well, but generally it can be a positive. Immunisations, again, Sarah will talk to you a little bit about the COVID one, but some people do have worse reactions to immunisations, but the majority don't. And so that's something to consider and discuss often with your doctor. But regular maintenance of looking for what we might have in the way of new medications, new symptoms that might occur need to be thoroughly and properly investigated, and we need to keep an eye on the possibility of new treatments or different treatment, because everyone with this illness tends to be very different. About a third of the people I've seen over time, we've often ended up with an alternative diagnosis. Things, you know, can change over time, and so sometimes people will get another illness, a different illness, on top of their ME, or we may have got the diagnosis wrong. And as doctors, we do get the diagnosis wrong quite often, despite working very hard to try and get it right. People with this illness have been shown to age a little bit more rapidly, not necessarily die earlier, which is encouraging, I suppose, but, you know, people will often say they get, you know, perhaps more likely to get skin changes, hair changes, you know, looking a bit older, and there's some good genetic explanation for that now. And there is a slightly increased risk of cancers, particularly lymphoma. So again, regular sort of following on, watching what's going on if symptoms change and getting proper investigations done and so on. I think we can say all symptoms are aggravated by stress, over-exercise, over-activity, so learning to pace is really important. Getting outside in the daylight, not just through a window, but actually outside, because your vitamin D levels can get very, very low if you're not outside in the sunlight, and that makes you more tired. And learning some really, really good relaxation skills, because that can help with a lot of the symptoms. So that's an important kind of message to get through. We might have a little bit of time in question time to talk about medication, but the one I will mention is low-dose naltrexone, and I'm only mentioning it now because so many people seem to be asking me about it. But the rheumatologists probably 5 to 7 years ago found that this drug naltrexone in very, very low doses had some benefit in pain, which of course is a major symptom, and their research has gone on, and we use this drug now in very, very tiny doses, particularly helpful for pain, particularly headaches. It quietens down the inflammatory changes in the brain. And also for some people it is beneficial for sleep, but some people do get insomnia. And I would say a third of the people I've put on it don't have any benefit whatsoever. About a third of them will say, yes, there is some benefit, and a third will say, I feel terrible on it. So, you know, you're kind of always wishing for something that fixed everybody, but I think it just emphasises how very different forms of this illness there are, many different forms. Of course, going to a support group is really important and helpful, and we have, very lucky for people in the Bay of Plenty, you've got this wonderful group that's brought you all together today. But the national organisation, MNZM, also can provide you with a very good magazine and all sorts of information sheets and what have you. So these websites are obviously very readily available. But I think, you know, my final word always is that all these patients experience a better quality of life with compassionate care and a multidisciplinary approach. You need to feel in control of your health rather than being controlled by the disease. And these are some resources. Again, you can hardly read them, I know, but I think your support organisation can provide you with them, and possibly you can even download or get copies of this PowerPoint presentation and the other ones we're doing today. And oh yes, and I I've got another new book out. This is the fourth one really, but I've only really written 3, and this fourth one is a upgrade on the very first one. And I'm not here to promote it, but I wrote the books thinking, oh well, if I write these books I'll be able to retire because no one will need to come and see me anymore. And I'm afraid I've just got busier, so I think we can end there. And yes, I'm sticking to my time, and Sarah will take over, and we're having question time, I think, at the end, aren't we? Yep, okay. So she can find her.